So what do you think are like the key challenges today faced by the nursing homes, and what you think could be the probable solutions?
A 25 bedded nursing home, if we cost one bed at 1 crore, they have 25 crores valuation. But how are they going to get it? So nursing homes have to change their thought process. They have to come together and decide how to take on certain things. Is that if a occupancy rate of a nursing home is say 60%, 70%, 50%, 40%, or 80% or 100%. Those who have 100% are very happy. They are trying to discharge their patient earlier. But those who are at 60%, and my information or talks with my colleagues across industry talk about 60 to 70% is good. Let us assume we all know that the overall treatment cost for a person is much lesser in nursing homes than in a tertiary care hospital.
Pretty interesting that health actually has four aspects to it.
Remember something, that when a patient comes to the hospital, he pays for two things. He pays for cost of cure and he pays for the cost of care. Now, care setting can be 3-star, 5-star, 7-star, and that's how the bills happen.
Today we are honored to have Dr. Nayan Shah with us. Dr. Nayan Shah is the founder and chairman of Paramount Health Group. Apart from being a very successful radiologist to someone who's built and scaled hospitals and now an entrepreneur, his journey is truly inspiring, and there is a lot which he has done in the health insurance space.
We believe that every doctor has a story behind him. We are in conversation with Dr. Nayan Shah, a master, not just a medical professional, but also a medical entrepreneur. We have been in conversation with him where we are learning lots and lots more about what goes behind a person who reaches this caliber and this heights in their practice, whether it is medical practice or medical entrepreneurship. When an average doctor starts his practice with lots of dreams and lots of future visions, they start with the practice, do well in their life. But when they retire, normally their assets, their nursing homes, their hospitals turn out nothing more than real estate. When the whole world is talking about small and middle sector enterprises and the buzzwords is SME, why is it that the real estate is the only thing left after the legacy of a doctor? This is what we need to learn and understand more from our guest today.
Thank you very much for calling me here. It's really a pleasure to discuss the subjects with you.
Sir, what do you think are your thoughts behind the challenges faced by nursing homes today? And what do you feel the future holds for the small and medium nursing homes?
Before we get on to nursing homes, I personally feel that everyone should know what is the industry of hospitalization and how it started in India. See,
Right.
in India, indoor hospitalization started when Britishers were here. They put up army hospitals and then other hospitals, government hospitals, etc. Then a lot of community trusts came in and they put up their charitable hospitals for their own community, where even others could get admitted, etc., etc. So this was kind of philanthropic activity which started as hospitalization in India, where infrastructure of a hospital was built up. What happened was that the admitting rights for these hospitals were limited. Very few doctors were allowed to admit patients in these hospitals. And there were a lot of doctors who were coming out, who were graduating, becoming postgraduates, and they had nowhere to admit their patients.
This is an amazing thing that you're telling. Meaning at one end, the doctor-patient ratio at that time was so skewed, but still the infrastructure created originally was limiting the availability and accessibility of doctors.
Yes, and
that's
new
an interesting
doctors
thought.
who came up were wondering where can they take their patients. So
Oh.
they started thinking that why can't we have our own facility. This is how smaller nursing homes came up. And obviously in tier 2 and tier 3 cities, there were no big hospitals. So they had to perforce start their practice or start their surgical practices or OBGY practices or whatever kind of practice to have their own place or a friend's place or an uncle's place or somebody who is different who is owning that place but allowing them to admit the patients. So this is how the nursing home practice started and flourished. If you look at, say, Mumbai, when we were studying, when we were in college, there was no big hospital beyond Nanavati, Parla. Kokilaben came later on. And beyond that, the population was shifting. And they had only nursing homes to go to. So nursing homes flourished. So this is the basically part of nursing home evolution. After that, what happened was that corporate sector came into the hospital industry. It started with Dr. Pratap Reddy, Apollo. We all know about it. And corporate hospitals started coming in. In last 10-20 years, even the insurance field has come in. Lot of private equity funds have come into the picture where they are giving money to chain of hospitals, etc., etc. So you are seeing that more than 100 beds or 200 beds hospitals are flourishing and expanding. Nursing homes are still there, but what has happened is that they have not many times upgraded their facilities. It requires, see, any hospital industry is a capital intensive industry. And they require certain funding, certain upgrades, certain upkeep, etc., etc. And traditionally, when a doctor had started, he was, I would say, successful in his practice, in his nursing home practice, did not look at expanding or anything. For example, how many doctors who had their nursing homes have more than 2 or 3 of their own nursing homes? So they did not expand into all these activities.
So this is interesting, meaning the corporate approach for growth and development of the whole business setup or a entrepreneur model is to scale up with replication, which is what is lacking because most of the nursing homes were keyman organizations where there was one individual running everything. And he is the CEO, he is the MD, he is the CTO, he is the CMO. Everything is run by that one individual. And probably that's why they were never able to scale up.
Absolutely right. See, when we are doctors, when we get admitted into medical course, we are never taught certain things, which is finance, which is business, which is entrepreneurship, which is so many things what is happening in the world around. So suppose if we were to ask a nursing home owner that what are the footfalls coming to your place or what is the per square foot earning of your nursing home, I mean, they will scratch
Now
their
he's
head.
scaring the doctors.
They will scratch their head because they have never learned this. They have never thought about all this. See, I have some friends who have their facility, maybe a general practitioner, maybe a nursing home, but next door industry, if you look at their earnings vis-a-vis a nursing home's earning, or if it is a GP, I know a GP who has a chikkiwala next door to his clinic. And chikkiwala earns 10 times more than this doctor. He is not even educated. So we as a doctor or as doctors, we have not really concentrated on financial aspects, on economical aspects, how to make more money ethically, and somehow we have not even looked at our costing and pricing. So you will still find a practitioner charging, say, 200 rupees for consultation, 500 rupees for consultation, or even 5,000 rupees for consultation. But what should be the bare minimum? Nobody has worked out. There is no 4 top consultants who are telling that by this is the way you should cost your practice.
So this is exactly what we want to train through Medical Monarchs to our fellow colleagues, that how you need to understand these nuances of modern management of your healthcare sector. So what Sir has beautifully explained is A, about accessibility, second, about affordability, and third, the pricing strategy.
So, like you rightly said, that finance is something which most of the doctors and particularly nursing home owners are missing out on. And like you said, the costing, not much understanding about what is a gross level, overall cost, even the differentiation between business finance and personal finance also. So what do you think are like the key challenges today faced by the nursing homes, and what you think could be the probable solutions?
Let me start it this way that I read a report recently about 6 months back where a corporate tertiary care bed was valued anywhere between 5 to 7 crores. So, a hospital having 300 beds, and if we average this out at 6 crores, is valued at 1800 crores. And then you are all aware of mergers and acquisitions, even into the healthcare industry, and see what kind of money they are making. Now, let's come back to nursing homes. Do they ever think about this? Have they ever thought about all this? How to go about valuing their practice or their business or whatever they want to call it? Even if, let us assume that a 25 bedded nursing home, if we cost one bed at 1 crore, they have 25 crores valuation. But how are they going to get it? They have to start thinking about that. Today, a lot of doctors have their children or their niece, nephews, etc., who are into finance field, who are into merchant banking or private equity or many other fields. But as a doctor, they don't go and talk to them. Basically, what had happened was that before some years, or even now at major part, the business basically is a cash business for nursing homes. And since it is not coming everything into white, they just have to manage their cash, and there are very less avenues. Real estate was one, Benami stocks were another, etc., etc. But these avenues are closing down, and more and more insurance patients are coming in, corporate patients are coming in, where there is a third party payer who wants to know the transaction value. So the doctors were not accustomed to all this. So now the practice patterns are changing, and nursing homes have to also realize that how to change their practice or how to change this pattern where, for example, in COVID, every even general practitioner was getting paid by GPay. It went into their accounts and they had to declare it. Same thing in nursing home. So nursing homes have to change their thought process. They have to come together and decide how to take on certain things.
That's an interesting thing, sir. So, from what he's mentioned just now, there are some very salient features which come out. Number one, sir talked about valuation of nursing home. Probably Nehal would be able to give us more about that valuation data. When we talk about valuation, we talk about the extrinsic factors and the intrinsic factors. He very beautifully explained that the extrinsic factors which we have has been, as per the report he mentioned, has been created, a benchmark has been created. But the intrinsic factors is what our doctors don't realize. A, what is actually the valuation of their practice, and B, how can they do the whole practice with that set in mind to have a corporate approach. Another very important aspect which sir mentioned about was adaptability. With the changing scenario of the financial ecosystem of the country and changing scenario after that landmark speech of Mere Priya Mitro, which changed the whole dimension of our country from cash economy to the actual official economy. And I think that's a great thing that has happened to our country, because now more and more, let me also express that more and more people are comfortable in paying through these platforms, which was not earlier. And if we do not adapt to that, it'll be difficult.
So, what would be your advice to doctors that how can they actually go about corporatizing their setup and basically start thinking of scale? And like you rightly said, that the current nursing home setups are about 10, 20 bedded, and they'll have limitation because doctor is also a practicing doctor there. And together with being a practicing doctor, he's also entrepreneur. So, given this both hats which a doctor wears, what do you feel is the right way for scaling up?
See, in finance or in any business, there is revenue which is coming in and there is expense which is going out. And the better is the difference between them, better is the earning. Simple mathematics which we learned in school,
The profitability.
profitability. Now, how do you increase profitability is one thing. How do you increase revenue is another thing. And how do you reduce expense is a third thing. Now, a small nursing home, uh, do they do marketing? The only marketing they do today is meeting practitioners around the area. Maybe once in a while they may go to one or two corporate bodies and introduce themselves, etc. But they are limited only to their own practice. For example, a, a surgeon who is, let's say, gastrointestinal surgeon, will talk only about his surgery. At corporate level, the corporate person who is a decision maker is not interested in only one solution or 1/100th of a solution. He wants 100 such solutions because there are so many types and types of practices. So the marketing part to get more footfalls, to get more patients is really missing out. Then let's talk about creation of awareness and a lot of things which ideally is needed to inform the client base. How many nursing homes have advertised that I have done 4,000 cholecystectomies? Or surgeons, whosoever, they are specialists in various things. For example, some surgeon may say that I have done 25 lung transplants. Then people will talk about him. But today, there is no benchmark for practice. I'm not even talking of quality. Right now, I'm talking of quantity. But that also, people are not aware, or the basic clientele which can come to you, they are not aware of your expertise. And third is expenses. When expenses, they have to be done. If you need certain material, uh, it you go and buy it. Maybe you ask for some discounts, etc., at nursing home level. But if there were 50 nursing homes uniting together for the same thing, then they would definitely get better discount. But here, what happens is, and I'm sorry to say this, but the trust factor amongst medical community on trusting one another is missing out somewhere. If they were to unite together, then wonders can happen. A lot of things can change. Lot of things can be done in appropriate way. Just yesterday, after this incidents of Kolkata, I was talking to some people who have nursing homes. एंड देवर सेइंग यार आजकल तो पेशेंट मारते हैं और द लॉट ऑफ हल्ला गुला हैपन्स एंड वी आर नॉट सिक्योर सो what is to be done? Simple answer was that suppose let's take a suburb called Ghatkopar, and if there are 100 nursing homes in Ghatkopar or 50 nursing homes in Ghatkopar, all of them can put CCTV and they all can be aligned with a police station. So if anything is happening, it is captured by CCTV. It should be advertised that I have this CCTV which is linked with this police station. This is possible, this is doable. And then anybody who wants to do some kind of hooliganism will not do that, or will be threatened. If he does something, he will be immediately caught. And you just press a button, like you know about banks, that if some goons go there, then there are buttons and police station gets that alarm and they come. Same thing can happen here also. But what is necessary is that this 50 nursing homes to unite. So there are solutions available. One has to think out of box, and that everything can be addressed. Maybe not 100%, but at least if you achieve 70%, that should be good enough.
Now we come back to our core question. The core question is that how can we look at uniting together, in spite of what Sir mentioned about the trust issue, how can we come together for some reason? So one of the interesting point is that the driving force for people to come together can be security concerns. That's an interesting way to put it, that your security concerns will unite you. But probably, let's talk a little bit more about how the financial aspect can help us unite together. Because I think profitability is a core value for every human being, and that will help us to unite together. So, security, yes. What about financial security?
Perfect. I'm talking on behalf of nursing homes. Every nursing home wants more footfalls, more patients coming in, somebody doing marketing, somebody helping them out in administrative activities, etc., etc. So they need to unite. See, it is ultimately the doctors who have learnt about health. Now I'm slightly digressing into what our business is. Today, most of the doctors, their business is treating patients. Now, how many percentage of population is sick at any given time? Maybe 2%. Maybe 2% of the population is seeking hospitalization or treatment at any given time. That means 98% of the market, which is not seeking your advice, you are just forgetting about them. But in our medical learnings, we have learned everything about health. Health is divided into four segments: promotive health, preventive health, protective health, and curative health. Rehab becomes part of cure. And if you
That
look
was
at,
an interesting pointer.
Yeah,
Can you repeat
actually,
that?
pretty interesting that health actually has four aspects to it.
we have learnt everything about health, and we also know that healthcare lies from womb to tomb. So that child who is conceived and sir does ultrasound and tries to find out how is the child,
Who
etc.
knows better than an obstetrician, sir?
Exactly. And then the entire life cycle of a person is divided into different age bands. Why it is divided into different age bands? Because the healthcare requirement is different for these age bands. Say infant, then toddler, or early school, then middle school, then adolescence, then adult, then male and female, where females undergo their cycle of pregnancy, etc., etc., then middle age, then retired person, early retired, then crippled or chronic disease which have set in, etc., terminally ill. There are so many age bands wise different events happening, and they all require different kind of these four segments. Promotive health for a toddler is different than promotion of a health in a young person who will go in a gym or something, and for elderly person. So same way preventive, protective and curative differs in these age bands. We all have learnt it, but we never practice that. Today, suppose in a general practitioner's clinic, in the afternoon hours, you call healthy people, talk to them about better nutrition. You will still generate revenue, you will have more footfalls, and you don't have to, your clinic will always appear full. Same way for nursing homes. There is an orthopedic surgeon who may call a physiotherapist. But lot of gynec nursing homes or obstetric nursing homes, they have started doing this antenatal and postnatal physiotherapy now, but earlier it was not being done. So the area was lying vacant. Now another thing is that if a occupancy rate of a nursing home is say 60%, 70%, 50%, 40%, or 80% or 100%, those who have 100% are very happy. They are trying to discharge their patient earlier. But those who are at 60%, and my information or talks with my colleagues across industry, talk about 60 to 70% is good.
I think, yeah, it's too good. Normally, the average is below 30%.
Wow.
Yeah,
Then
I'm
what
going to
are
be
we doing
factual.
for the
Yes.
remaining space which is available to us to conceive how we can generate revenue out of it?
So when we take out an average for the whole, month or a year, then occupancy is lesser because 30% is always kept free for the emergencies. Especially, for example, if there is an obstetric unit for patient to walk in, you always need to have some beds free, irrespective of the fact that it is better that all the beds are full. But you will have to have free beds because when the patient walks in, the bed availability should be available. Because they do not have access to, and as you said, trust issue, that if it is full, we cannot use the unutilized bed of a friend or any other hospital. That's an
So
interesting thought.
yeah, and if you are letting your space remain vacant for whatever reason, you may have your friend who is also obstetrician practicing maybe 2 kilometers away, and calling an ambulance and sending them, and you going and doing the delivery there can be achieved, provided trust factor
Trust
is there.
factor, yes.
And so there are a lot of things which can be jointly done. And let us assume we all know that the overall treatment cost for a person is much lesser in nursing homes than in a tertiary care hospital. Insurance companies or government are also looking at reducing the cost of treatment without getting the quality affected. There are advantages of nursing homes where the nurses are very cordial to you. They are just moving around and you just have to shout and they come. Doctors are also available round the clock or most of the time, which doesn't happen in tertiary care hospital. You once a doctor has visited you, he will come next day, and then you have to depend on the RMO, and RMOs cannot decide. They have to talk to the consultant and then come back and tell you, even if you have pain, to give a dolo or a crocin or aspirin. They have to go back and you may have to wait. Here you don't need to wait. So there are certain ailments which can be very well treated in nursing homes, but this is not being promoted. This is not being informed. Population is not aware of all this. So all this nursing homes can join together under one umbrella, and then all this can be done. For example, let's say a corporate which has 30,000 employees and is insuring their entire workforce and paying certain premium. Now, the premium today by insurance companies is calculated on their experience of overall statistics. They are not doctors. They just look at the numbers, statistics, what is spent, and what is the administrative expense, etc., distribution cost, and all that. So this premium gets increased. But if 40% of that treatment, which can be done in secondary care nursing homes, was done there, then the outflow would have been much lesser and their premium would have been lesser. So, how to drive that towards that? For that, nursing homes have to come together and create something and inform all these corporates or common population that no, we are there, we can do better, we can look after patients better. See, ultimately, if there is a malaria case, same medicine you are going to give, whether in tertiary care or whether in nursing home. But remember something, that when a patient comes to the hospital, he pays for two things. He pays for cost of cure and he pays for the cost of care. Now, care setting can be 3-star, 5-star, 7-star, and that's how the bills happen. Now, if in nursing home you can define better care, then you could be a winner.
In fact, while you were talking, you've highlighted a very important point, which is very popular in the retail industry. It is a revenue per square feet. And what you said that apart from the care and cure, you also are holding a lot of real estate. And if you have to increase your revenue, then you have to be mindful of the fact that what is a revenue per square feet. So, any ideas, like you did say about, say, a gynac having, postnatal physiotherapy or letting his place out to a nutritionist or, like setting up a neonatal facilities. So, what can he do actually to increase or drive up the revenue per square feet? So, any more suggestions on this? Because for driving the valuation, now particularly in the nursing homes, I feel this point about revenue per square feet is pretty important, and doctors should start thinking in terms of how they will, increase that footfall and revenue per square feet.
See, there are a lot of examples in the world. I can start with primary care practice. I can go to nursing homes as well. In primary care, uh, in Pakistan, for example, the general practitioners have also a provision store along with.
Oh,
So a person coming into a clinic can buy some creams or beauty things or etc. etc. This was replicated in US, where the pharmacies like Walgreen or CVS, etc., they started having primary care clinic in their own pharmacy. So what happens is that not only the footfalls come in, but they also purchase lot of other ancillary things that increases revenue. Now, this was a unique thing when I first read about all this. And then I also thought that see today what happens in primary care, the doctor either gives a prescription or dispenses medicines from his own kind of compounder does it for him. Tomorrow, when the things are going to be very transparent, the third party payer, which could be insurer or government or anybody, is going to ask, what have you prescribed? And why have you prescribed branded and why not generic? Because eventually the third party payer is considering the cost. So all these are likelihood changes which are going to come. Doctors will have to prescribe, and this will go into the National Health Claims Exchange, etc., etc. But these days are yet to come. But for nursing homes, it has come. For indoor hospitalization, it has already come. So what can a nursing home do? See, today, let us say that what is per bed revenue of a nursing home? It's not just rent, what you charge for the bed. Overall, you have to calculate what are the OT charges if surgeries are done, what are the
So what
medicines
he's
you are
trying to say
sending.
is revenue, or what he's trying to say is revenue generated per admission or per occupancy of the bed
No, you
from
have
also.
kind of limited square foot area.
Yes.
And like Nehal was saying that per square feet in retail, same thing. Per bed here, what is your revenue? You may want to kind of dissect it into single room bed, twin sharing bed, or a general ward bed.
Yes.
But every nursing home would have those figures. And then what is to be done? How it is to be done ethically. I am not saying that just a single bed you make it a ICU and start charging like that, because this will not sustain in long run. You may get away for a couple of years, but it's not going to be sustainable because the awareness is coming in into population. Third party payers are becoming more and more aware, so they are going to scrutinize your infrastructure and everything. But if nursing homes are united, they will learn what needs to be done.
So I would like to ask you a question here. With the changing government model of cashless for all, and with the need for enrollment for all the nursing homes, and you being, I don't know whether to use the terminology of Bhishma Pitamaha of TPA or the Chanakya of TPA, with intellectual expertise, you have created a system and service for getting this standardized and the workflow management for insurance to be eased up in a way which India had never seen. So, where do you see the merit of these nursing homes to create use of technology for upgrading their system and creating a standardization in practice?
Yes, a very important question. And it requires nursing homes to really reflect on what they are looking at their practice 2 years hence, 5 years hence, and 10 years hence. Let's not go beyond 10 years. We all are talking of digital Bharat. We are talking of digital era. So we are talking also of digital health. Today, most of the nursing homes would have at the most a small HMIS, a kind of software for admission, appointments, etc., etc. But they may not have linkage or an API linked directly with the National Health Claims Exchange. And all this is coming up. Today, you are probably scanning your medical records when a patient goes out in PDF format. It's not digitized. So even if you want to understand the analytics of what was being done, say in a tertiary care hospital where there are 10 surgeons coming in, which surgeon is using which medicine? Today, they would know by just practice, but there are no proofs, no digitization of complete things, which will eventually be needed because everyone wants to make more and more profit.
So, don't you think with this Ayushman Bharat digital mission, where they are creating a standardized ecosystem like the ABHA card and the hospital professional registry, which is being going to be maintained. So the APIs will be connected to these digital platforms and become a compulsion in a due course of time.
See, there are aggregators today who are going to various nursing homes and telling them that we will do it for them. But then the DPDP Act comes in, Digital Data Protection and Health Privacy, Health Data Privacy Act. So this is right now being discussed at government level. If today, say mom and pop owned nursing home do not know much about IT, they do not know how to go about doing things. So they depend on vendors,
Oh,
and
that's
these
an interesting.
vendors will take certain amount per case from them, etc., etc. And there are such vendors even today available. But the question here is, you are passing on health data to a third party, and whether that third party will sell this data later on and make money or not, you don't know. So there are a number of things which are being discussed
So
at
this is going
National
to
Health
be.
Authority level
Yeah. So
today.
NHA, what I've been told is just like UPI, a UHI has been created, and there is going to be a digital interface, and it is part of our digital health public infrastructure, where the UHI will be a common platform which will ensure privacy and consent for transmission of data. But still, the data will be stored at the end of the hospital or the people where it's going to be generated, a lab or whoever is going to be treating the patient. And that risk is always there, as you're saying. So,
I
do you have a solution for it, sir?
I am working with NHA on this right now,
Oh, brilliant.
and we are trying to change, or at least I'm recommending them to change the way it was being done, say, last month.
Okay.
See, what we saw was that in NHCX, or National Health Claims Exchange, they expected hospitals to do a lot of stuff. They expected hospitals obviously to first register. There are two registrations required. One is called participant ID, and second is called HFR, Health Facility Registry. Both are almost the same, but then there are two emails which need to be sent. Then they expect that whenever a patient or an insured person goes there, or a government scheme person goes to the hospital, they will take consent and create ABHA ID. Now, ABHA ID for, say, in his case, a newborn child, and if he needs treatment, where is he going to create ABHA ID? Because there is no Aadhaar card. Aadhaar card needs to be linked with, then ABHA ID will come in. So there are various steps, and if it is not that, then he can create ABHA ID with mother or father or whatever. Then they had to go to that platform to check what is the eligibility or what is his policy. Now, nursing homes are not aware of what are the different kinds of insurance products, insurance benefits, etc., etc. But still, they have to look at it, and then they have to upload their pre-authorization request. So obviously, this is a lot of IT work. Another thing which is coming in is that hospitals are today aware of ICD-10 coding. But now Government of India has gone with SNOMED, which is a different kind of coding. And eventually they want all the doctors and nursing homes to give the coding in SNOMED, or the procedure coding in SNOMED terminology, where there is no training given to any nursing home or any doctors. So all these are the changes which are coming in. Government has already decided SNOMED. So eventually it will be done by insurer at back end or TPAs at back end, or nursing homes will have to be trained with a small software. So it's all a software. Once you have your diagnosis, you can attach it with ICD-10 code. Vis-a-vis, you can attach it with SNOMED code.
So, why can't the government provide us, or maybe the insurance company provide us with a standardized, information management (HMIS), or maybe a ABHA card connected patient health records?
Insurance company may not be able to provide, but they expect you to have it. But now we are trying to eliminate that.
Yeah, so what I am
See,
coming to, sir, is
yeah.
that if we have a common reason why all nursing homes can come together and we have a common system which everybody follows together. If we have a standardized way of practice, only then will the valuation happen.
Yes. And say, for example, let's say there are 10 nursing homes in Ghatkopar which are empaneled with some corporates or with some with some insurance companies, etc., which gives them a certain assurance of footfalls, patients going there. Then obviously their valuation has to be more than just real estate. So the unity and getting into uh, a comprehensive company where they have assured footfalls will definitely increase their valuation. Today, a diagnostic center, for example, if they are associated with 10 insurance companies whose patients come for, say, pre-policy checkup, so they can boast that itna patient to aane wala hi hai. This is my last 6 years average or 3 years average. So my valuation has to go that much up. So these are the ways by which one can start thinking of increasing valuation. Which,
Okay.
and if they are united, but I'm going one step further. Why can't nursing homes unite and start their own health plans?
This is, I think, amazing. What you're saying is that all nursing homes and hospitals come together and create their own health plan. Now, that's going to be real revolutionary.
See, ultimately, the patients come to you. You are the doctors. Patients have trust in you. Why should be they told that no, no, you go to this hospital or that hospital? This is in our network and these, etc.,
Which is
etc.
anyway illegal under the IRDA.
Uh, but somehow they want patients to go to 100% cashless network. And what is happening is that not every hospital is coming into the network. There are a lot of issues of various hospitals getting into the network who had learnt medicine, became MBBS, then MD, then constructed diagnostic centers, built hospitals, and then into healthcare economics. Why can't we doctors unite, nursing home owners unite, and create our own health plan?
So, Dr. Nayan, you rightly pointed out that the medical practitioners or the small and medium nursing homes should unite. And very jokingly, one of the gynacs always used to tell me that we are an army of generals. Okay, and we need to really change our mindset. And if you look at the nursing homes, the core activity of a doctor is to focus on health overall. But apart from just focusing on health and treating the patient, there are a lot of other activities which goes into running and scaling a nursing home. Like you rightly said, marketing, finance, now even tech, that's becoming like an important aspect, social media, and purchases. So how about all the nursing homes coming together and they just focusing on the core activity? What they do the best is focusing on the health and the cure for a patient, and outsource all these non-core activities into a kind of an aggregator, which is again something which is floated by all doctors and nursing homes together. So what are your views on that?
Views are very simple. Yes, they should use aggregators or a trusted company which can do their administrative jobs. For example, a nursing home may require about 50 licenses which needs to be renewed every year or every second year or whatever. Then there are issues about having staff, nurses or nurse assistants, etc., etc. And doctor has to concentrate more on his core competence, which is his speciality, and getting more patients, treating them well, etc., etc. But what has happened, Neil, is that the nursing home revenue, when we were talking about cash part and non-cash part, there is lot of revenue which is coming in a different way. For example, they have tie-ups with some diagnostic centers, or they have tie-ups with some pharmacies, and they have tie-ups with certain other vendors, etc., etc., where there are certain equations set, and they, nursing home owners, don't want these equations to be touched, to be known, or to come in any which way, and that is where they are not even able to unite today. But if we keep these equations aside, there are a lot of areas where they can immediately go for help. Like one I talked about, say staffing, or say security part, or marketing part, or administrative part, etc., etc., IT part. There are a lot of things where they can unite without affecting their current way of practicing. And this is what is needed first. The corrections which need to come can come later, but first thing is to unite first. And where can they unite is are these things. So there are a couple of companies which have started all these activities in Mumbai to begin with, and they will be going from October onwards to nursing homes with these solutions. Second thing which I really wanted to talk about was marketing part, or empanelment in government schemes part. Today, because each nursing home tries to get empaneled alone, they don't have that strength, or that kind of unity is not shown. But let us assume that with government patients, even if you are able to fill 30 to 40% of your beds, you are still getting certain revenue. You may not get huge profits, but you are getting revenue. And whether like CGHS, you can decide and tell government that, okay, I will do only these surgeries. That also is a possibility. But there is no unity, and there is no body which can advise them on these things. So all this is coming out by October, November in our country, and this will happen. Another thought which I had, Nehal, was that we as doctors, whether we are primary care practitioners or nursing home owners and specialists, etc., etc., but when we are a layman at home, we think about our entire family for healthcare. It's a unit. My parents, husband and spouse, my children, I'm worried about the entire family for their health. And this, I don't have any advisor. You, being expert in finance, you can become a wealth manager. You will advise doctors to where to invest, what to be done. You will monitor what is growing, what is not growing appropriately. You will go back to the consultant or your client that, okay, let us change from this to this, etc., etc. Are there any care managers for a family unit?
Wow, wonderful thought. Like we have financial advisors or wealth managers. Why wouldn't a family actually have a health manager or a health advisor where, like you rightly said, that we as patients really think of going to a doctor only when we fall sick? Why not actually start going to a health advisor, to just be fit?
You don't have to go to health advisor. He will come to you,
Oh,
or
wow.
he
So
or she will come to
this
you.
is going in line with the original Alma Ata declaration of the primary healthcare. Make the healthcare affordable, accessible, and at the doorstep. I think care managers is an interesting terminology. With more and more people, with more and more aggregators and applications available on our mobile, where we just by a flick of button or a click of button, we are able to get whether it is a groceries, whether it is our transportation, or whether it is our day-to-day services. Why not the most important component of our life, our health care services available to us? Maybe doctors are going to be a difficult resource to be mobilized, but a care manager who is equipped and trained for the basic awareness about how the systems work and is a coordinating person between the healthcare setup and the family. That's an interesting thought.
Very true. Another thing which is coming up by an initiative by government is they want to promote Ayush. We all have heard about this.
So, a quick word about Ayush scheme.
Ayush is allopathy, Ayurvedic, Unani, homeopathy, and Siddha. So, but how many people, a general population, know anything about homeopathy or Ayurveda or Unani or Siddha? So, government is trying to come out with a free call center for entire country, which will be manned by nurses, and who will advise that, okay, somebody says I have got piles or fissure or fistula, what will work? Ayurveda will work, homeopathy will work, or should I go to a surgeon? When should I go for operations? So these are the kind of things which are happening in our country and which can change a lot of thought processes and thinking. So we doctors have to kind of be uh, in sync with what is happening in the world, what is happening in our country, how it is going to affect our practice. Is it going to be good for us? Is it going to be not so good for us? What should we do to kind of advertise ourselves to the population, etc., etc.? So a lot of things are coming up. The company which I told you is coming out in October, and they are targeting 100 families where they are going to give care manager free for 1 year. And what will happen is that they will be accessible if a family member wants to go to a pediatrician, or suddenly the weight of the child has increased. So everything will be monitored. And I talked about different age bands. Depending on different age bands, what promotion to be uh, informed to them and monitor that. And with aggregators happening, today you can go to gym even for a day and pay a daily fee because there are aggregators. Same thing, whatever is required in health will be given at a hugely discounted cost. So things are moving in that way, but we doctors need to take it in our hand. Today, if say, I would say 500 nursing homes unite and invest together with another company, they have their own health plans. They can create their own health insurance company. So, and patients come to them first. Please understand. The trust of a common patient is to a doctor. And we don't want that to go away as medical practitioners. And this is where we need to think. And this is with this theme, we need to unite. I'm aware that there is one giant corporate house pumping in 20,000 crores in healthcare, but they have not yet found how to break this trust factor. They are struggling. They are asking people around that kaise kare ye. So how to conceive a complete project because of the trust factor. Howsoever I may advertise, but my wife still wants to go to the same family doctor which she has been going to. So these are the things which are our strength, medical practitioners' strength. And if we don't utilize it properly now, then over a period of time, we will become like Kirana shops.
That how do you see your organization helping this whole ecosystem?
Unfortunately, Mukesh, we are a TPA. Our primary activity is TPA. And until and unless we are into this field, we cannot become a health plan company or a health insurance company.
Oh,
So there are two options. One is that if regulator allows us to expand into our TPA field, we can incorporate overall healthcare. Otherwise, we have to kind of dispose this company off and get into a health insurance company. So we are wondering that we have a shareholder and which is Fairfax of Canada, and we are wondering what course we will take. But whether we become a health insurance company or not, our parallel company is floating this care manager concept and overall health plan subject. And we have enough resources initially to experiment at least 100 families in Mumbai, 100 families in Bangalore, and 100 families in Delhi. That has been planned to commence from October, November. We have already created a team, and we parallelly have 150,000 beds pan India, which are under our network called Health Bridge Network. And here we are going to give them administrative support, marketing support, etc., etc. So a lot of concepts are being developed.
So this health bridge concept is a very interesting concept. So can you elaborate a little more on that health bridge concept?
This started with all the issues of nursing homes and how we can help them. And suddenly, in last 3-4 years, we have seen that nursing homes are even going down when Ayushman Bharat is not allowing nursing homes to do surgeries. They are selecting a few hospitals and so on and so forth. So everyone is not getting insured or third-party payer patients. So how to get them more patients? So we started some activities and it was found to be very successful. We created a certain network, say in Mumbai to begin with, and there were local SMEs or some trust bodies who did not want to go with insurance, but they wanted their money to be saved. Their beneficiaries should not go for small things to, say, a tertiary care hospital, which can be treated in secondary care. So they came to us and we discussed and then we decided on this model, which has worked very well. So in last 4 years, there is no increase in their outflow.
Claims
It has
ratio.
been contained. Yeah, you can say claim ratio or whatever, but the outflow has been contained. So we started talking to corporates that look, if you want to save your premium or reduce your premium cost, then you will have to change your benefit product to or insurance product. So they are also in sync with this. So that's where this is being done, and October, November, this will come out. But idea is that we nursing home owners should unite and start a health plan company of our own.
So what are the services that you're providing under the health bridge platform?
Care
For a
manager,
doctor, for a nursing home owner, and for the patient. So you talked
right?
about the corporates. So that is one vertical, one of the stakeholders. You talked about. So I want you to tell us that what is HealthBridge going to do as service to the doctors and to the end users.
This is precisely what we are discussing right now. But HealthBridge network, as of today, see, a lot of nursing homes want NABH accreditation. So we provide them with complete guidance and how to go about doing things and assist them in getting entry level NABH accreditation, depending on where the nursing home is. Then we provide them administrative support. We provide them empanelment with whichever insurance company they want. We are now trying to get them empaneled with government schemes, Maharashtra to begin with, and then Ayushman Bharat. So, and we are also ready to give them administrative support, complete. Like 3 nursing homes, we are renewing all their licenses, etc., etc. But this is a longer subject, and licenses we have to go to government, and you know how government works. So the nursing home and the administrator part, they have to have complete understanding, because that is not our revenue model, but their
The value-added services you're giving
yeah,
to your
value-added services are given, and we keep the owner, nursing home owner, informed so that they don't falter anything, anywhere, anything. So this is growing. This is happening. We also have something called supply of nurses, training of nurses online. We also give them certified nurse assistants, and we are also into now skill development, training for nurses, nurse assistants, and for the market abroad. Because the nurse assistants or nurses who come here, they need to be groomed. Suppose if UK wants 1,000 nurse assistants, they need to understand English. So, but you know that healthcare workers' demand is huge overall across the world, and these are opportunities which we doctors can take it. We can train them. We know how to train them. So there are a number of things which Paramount Group is doing. So
That's very interesting. I think there's a very exciting way ahead, and I think we have to look at the space a little more. We'll connect more with Dr. Nayan Shah and get this futuristic thoughts and ideas for practice in day to day. What we have learned today is something which is beyond imagination in this such a small capsule. He talked about issues related to accessibility, affordability, and adaptability for the nursing home. And if we want to scale up And if a small nursing home has to have profitability, they have to have some unifying factors. For example, whether it is a security, whether it is staffing, whether it is administration, whether it is marketing, whether it is use of technology, or whether it is need for the regulatory compliance or empanelment for all those insurance vendors, which normally is a very important component of profitability and the footfall. The concept of care managers, you heard her first. Don't forget that. That's an interesting concept where every family can have their care managers who helps them to connect with the larger ecosystem of the healthcare around them. And we also heard a lot about the future directions that the Ayush or the NHA or the UHI or the government is thinking about by these tools to help us have a better healthy life. Thank you very much.
Thank you so
Thank
much.
you. Thank you very
Thank you so
much.
much, Dr. Nayan Shah. And I guess my key takeaway from this is that doctors should start thinking about the revenue per square feet. It's not just like the cost of surgery, but they are also sitting on a lot of real estate. So how do you actually start thinking about increasing the revenue per square feet, like you rightly said, and also that whole concept which you talked about, that how doctor can just focus on the key or core activity, which is the patient's health management, and everything other than that can be outsourced into an aggregator, which can also be created by so many nursing homes coming together. So these were some wonderful thoughts. Thank you so much for your time.
Thank you.
Thank you
Pleasure.
very much.